Hi everyone, we are from Group 5 for the Immunology workshop, and today we will be presenting a case study focusing on a patient who experienced complications following a blood transfusion, and these are our team members. Our presentation will cover the following case sections. Let's begin with the case scenario. Jack, our case study patient, was rushed to a hospital after a traffic accident. Although his injuries were minor, he required a blood transfusion due to blood loss. Based on his blood group card, he was given AB-Rh positive blood. However, an hour later, he experienced a drop in blood pressure and breathing difficulties. This case explores possible causes, including blood group incompatibility or immune-related transfusion reactions. Jack may have experienced a mismatched blood transfusion where he was mistakenly given AB-Rh positive blood instead of his actual B-Rh positive blood types. This incompatibility could have triggered an acute hemolytic reaction where the immune system attacks the transfused red blood cells, leading to symptoms such as low blood pressure and breathing difficulties. Another possible explanation is graft versus host disease, GVHD. Considering Jack's recent bone marrow transplant, in this scenario, the transfusion might have activated donor's white blood cells, which could attack Jack's tissue, causing immune complications. Alternatively, Jack might have suffered an allergic or anaphylactic reaction to protein in the donor plasma, resulting in symptoms ranging from mild itching to severe breathing difficulties and hypotension. Additionally, the breathing issue could be linked to transfusion-related acute lung injury, a serious condition caused by donor's antibodies interacting with Jack's white blood cells, leading to lung inflammation and impaired oxygen exchange. Lastly, iron overload or hemosiderosis could be a concern if Jack had received multiple transfusions recently, as excessive iron buildup can lead to organ damage, although this is less likely within the given timeline.
Now I'll explain how Jack's blood type changed after the bone marrow transplant and how this set the stage for complications during the transfusion. Blood type is determined by the ABO and RH system. The ABO system has three alleles. IA codes for the A antigen, IB codes for the B antigen, and I is no antigen. The RH system determines whether blood is positive or negative based on the RHD antigen. So before the transplant, Jack's blood type was AB-Rh positive with a genotype of IAIB. This gave him both A and B antigens on his red blood cells and no anti-A or anti-B antibodies in his plasma. After the transplant, Jack's genotype changed to IBIB or IBI, reflecting the donor's blood type. His red blood cells now only express B antigens, and his blood type became B-Rh positive. This change caused his plasma to produce anti-A antibodies which recognize A antigens as foreign. This means Jack was no longer compatible with transfusions containing A antigens such as AB or A blood. While this genetic change itself wasn't harmful, it became critical during the transfusion. Jack's plasma now containing anti-A antibodies react to the transfused blood containing A antigens. The immune response and its consequence will be explained next.
Jack experienced an acute hemolytic transfusion reaction, also known as AHTR, due to a mismatch between the transfused AB-Rh positive blood and his current blood type, which is BRH positive, which changed after a bone marrow transplant 6 months ago. The transplant replaced his hematopoietic system, aligning his blood type with the donor's genotype IB/IB for B antigen and Rh positive/Rh negative. The A antigens in the transfused blood triggered an immune response, as Jack's reconstituted immune system produced anti-A antibodies, leading to hemolysis, hypotension, and breathing difficulties.
An acute hemolytic transfusion reaction occurs when a patient receives a transfusion of incompatible blood, triggering an aggressive immune response. In Jake's case, receiving AB-Rh plus blood instead of his B-Rh plus blood introduced A antigens, which his immune system recognized as foreign because his red blood cells contained anti-A antigens. The immunological mechanisms underlying AHDR involves the recognition and destruction of the transfused red blood cells by Jake's immune system. Everyone naturally produces IgM antibodies that are specific and can recognize antigens that are not compatible and label them as foreign. Since the blood transfused into Jake's body was incompatible with his own blood, this triggered an immune response. So, in this case, the IgM antibodies bind to the A antigens on the surface of transfused red blood cells. The formation of antigen-antibody complexes causes the Fc regions on the IgM antibodies to be exposed. This initiates the classical complement pathway. The complement system is a part of the immune system that helps destroy harmful invaders. Additionally, the activation of the complement system leads to the formation of mechanism attack complexes. These complexes then enter the incompatible transfused red blood cell membrane and form pores. As a result, the red blood cells undergo hemolysis, which is a process where the red blood cells rupture, releasing its intracellular components such as hemoglobin, cytokines, and histamines into the bloodstream. The release of cytokines contributes to lung vessel permeability, causing fluid leakage and resulting in breathing difficulties, while histamines caused blood vessel dilation, leading to low blood pressure.
Next, we're going to take a look at the symptoms of AHDR, onset within 24 hours of blood transfusion. Fever, flank pain, dyspnea, chest pain, headache, nausea and vomiting, hypotension, hemoglobinuria, which means blood in the urine, flushing, edema, and agitation. There are few tests that can be conducted to diagnose AHDR. First, direct antiglobulin test. A positive DHT test will confirm immune-mediated hemolysis consistent with an incompatible transfusion. Next, serum-free hemoglobin. Elevated levels will suggest intravascular hemolysis caused by incompatible transfusion. Next, the indirect immunoglobulin test. It will determine if Jack has an alloantibodies against donor antigens, which could contribute to hemolytic reaction. Next, urine analysis. Hemoglobinuria is a hallmark of severe hemolysis and supports the diagnosis of AHDR. Next, blood typing and cross-match evaluation. A discrepancy between Jack's original and current blood type post-bone marrow transplant could explain the incompatibility. Lastly, blood cultures. Although less likely, a contaminated blood bag could cause symptoms similar to those of AHDR. Next, we're going to take a look at the management of AHDR. The very first step you should do is stop the transfusion and begin supportive treatment immediately. Next, we're going to do an initial therapy to maintain the adequate blood pressure and renal blood flow. We should administer IV 0.9% of saline to achieve urine output of 100 milliliter per hour for 24 hours and use IV furosemide 40 to 80 milligram, adjust dosage to maintain urinary flow of more than 100 milliliter per hour. Next is the pharmacologic management of hypertension. Avoid pressors that decrease renal flow, for example, epinephrine, norepinephrine, or high dose dopamine. If necessary, use dopamine 22 to 5 mcg per kilogram per minute IV continuously. Next, we're going to do a nephrology consultation. Consult early if no diuretic respond within 2 to 3 hours. Indicate possible acute tubular necrosis. Next, consider early dialysis if fluid or diuretic therapy is contraindicated.
To conclude, this presentation critically examined a case of acute hemolytic reaction following a mismatched blood transfusion. The analysis highlighted the incompatibility between the recipient's actual blood group and the transfused blood, underscoring the necessity of precise pre-transfusion testing to mitigate such adverse events. Furthermore, genetic basis of blood group systems were explored, focusing on the ABU and R systems to understand the immunological mechanisms driving these reactions. The slides emphasize the pathophysiology of hemolytic reactions, including the immune-mediated destruction of transfused red blood cells and its systemic effects such as hypotension and respiratory distress.